Welcome to our channel Easy Med, where we make medical concepts easy to understand. Today, we are breaking down one of the most common and preventable chronic lung diseases, COPD. Let's begin. Chronic obstructive pulmonary disease, commonly known as COPD, it develops slowly over years, most commonly due to smoking, and leads to breathing difficulty and reduced quality of life. Let's understand the definition clearly. COPD refers to a group of progressive lung disorders, mainly chronic bronchitis and emphysema. Chronic bronchitis means a productive cough lasting at least 3 months in 2 consecutive years. Emphysema means permanent enlargement and destruction of air sacs beyond terminal bronchioles without fibrosis. COPD is characterized by chronic inflammation of the airways, lung parenchyma, respiratory bronchioles and alveoli, and pulmonary blood vessels. The defining feature of COPD is not fully reversible airflow limitation during forced exhalation. This is caused by loss of elastic recoil and airflow obstruction caused by mucus hypersecretion, mucosal edema, and bronchospasm. In COPD, various processes occur such as airflow limitation, air trapping, gas exchange abnormalities, and mucus hypersecretion. The inflammatory process starts with inhalation of noxious particles and gases, e.g., cigarette smoke. The predominant inflammatory cells in COPD are neutrophils, macrophages, and lymphocytes. This pattern of inflammatory cells is different from that in asthma. In asthma, the inflammatory cells are eosinophils, mast cells, neutrophils, lymphocytes, and macrophages. Inability to expire air is a main characteristic of COPD. The primary site of the airflow limitation is in the smaller airways. As the peripheral airways become obstructed, air is progressively trapped during expiration. The volume of residual air becomes greatly increased in severe disease as alveolar attachments to small airways, similar to rubber bands, are destroyed. The residual air, combined with the loss of elastic recoil, makes passive expiration of air difficult. As air is trapped in the lungs, the chest hyperexpands and becomes barrel-shaped. Gas exchange abnormalities result in hypoxemia and hypercapnia, increased CO2, as the disease worsens. As the air trapping increases, walls of alveoli are destroyed, and bullae, large air spaces in the parenchyma, and blebs, air spaces adjacent to pleura, can form. Bullae and blebs are not effective in gas exchange since they do not contain the capillary bed that normally surrounds each alveolus. Therefore, a significant ventilation perfusion, VQ, mismatch, and hypoxemia result. Excess mucus production, resulting in a chronic productive cough, is a feature of individuals with predominant chronic bronchitis. However, not all COPD patients have sputum production. Excess mucus production is a result of an increased number of mucus-secreting goblet cells and enlarged submucosal glands. Pulmonary vascular changes, resulting in mild to moderate pulmonary hypertension, may occur late in the course of COPD. The small pulmonary arteries vasoconstrict due to hypoxia. As the disease advances, the structure of the pulmonary arteries changes, resulting in thickening of the vascular smooth muscle. Because of the loss of alveolar walls and the capillaries surrounding them, pressure in the pulmonary circulation increases. Pulmonary hypertension may progress and lead to hypertrophy of the right ventricle of the heart, cor pulmonale. The right ventricle dilates and may eventually lead to right-sided heart failure. That's all for today's video. If you found this video helpful, don't forget to like the video, subscribe for more medical learning content,